I'm Dr. Marin McDonald, an assistant professor in the Division of Neuroradiology at the University of California at San Diego. I've been in academics for 15 years, and I never thought that I would have occasion to speak on behalf of anything other than my own institution or my personal academic interests. However, my experience with Canon Medical imaging has been so exemplary that I felt compelled to share it with the radiology community in the hopes that this would provide benefit to other practices in the country. Now, there are a lot of factors which make Canon a true leader in medical imaging. Certainly, their technology is second to none, and they are in possession of one of the greatest clinical applications teams in the United States. But in my opinion, what truly makes Canon the leader of the pack in terms of MR imaging is their early adoption of artificial intelligence in image acquisition and reconstruction. And so today I'm going to tell you a little bit about our early clinical experience using this system at UCSD. In the interest of full disclosure, I am not an MR physicist, nor am I a computer scientist. In fact, I've always been somewhat of a skeptic when it comes to AI and what kind of relevance it would have to my daily clinical practice right now. But my experience with Advanced Intelligent Clear IQ Engine, or AiCE as we like to call it for short, has really reversed my position on this subject. So a bird's eye view, what is AiCE? Well, AiCE is an example of deep learning reconstruction, which is aimed at identifying and selectively removing noise from your MR images without sacrificing detailed morphology. So what Canon is doing is allowing the radiologist to see through this noise, and in so doing, to really get the most out of every single image that's acquired on each patient. Slightly more in-depth, AiCE is based on deep convolutional neural network, which is a deep learning method that is particularly tailored to computer visual tasks such as object detection and image reconstruction. For our purposes as radiologists, the way this works is that high-quality training data with a minimum of 10 averages is used to train the AiCE model so that it can identify and, by design, selectively remove noise from low SNR input images and then reveal the normal morphological data, but with the noise taken out. So once this training has occurred, this algorithm is really seamlessly integrated into your clinical pipeline. It operates in the background during image acquisition, really with no further input from the clinical radiologist. So from day one, you are acquiring these high-resolution images in the background when you use the AiCE system. But of course, we are radiologists and we are all creatures of images, and the proof is in the acquisition. So we'll start with this case here. This is a perfectly diagnostic coronal oblique T2 with a focus on the mesial temporal lobes and hippocampal formations, some of the most important but difficult areas to image in the brain. And certainly this is a very pleasing image on 3 Tesla. However, when you add the AiCE reconstruction, it's like the whole brain is revealed to you. I told you that this was tailored for the hippocampus, and certainly we get exquisite detail of the cell body layer, which lives in the hippocampal formation, which is exquisitely sensitive to many different types of insults. And even though the study was not tailored to assess the rest of the brain, there's a tremendous benefit of denoising here in the thalamus, and I can almost start to resolve individual nuclei within the thalamus. So this is what we call our virtual 7 Tesla images. It's important to note, though, that this was acquired with a relatively long acquisition. This is 6.5 minutes, so still clinically relevant, but longer than what most of us are using in practice. And so what I'll spend the rest of our time doing is showing you actual clinical patients with real clinical protocols and the types of images that you can get using the system from day one. So this is an orbit MRI performed with a T2 sequence 3mm acquisition. And what you can see is that there is some background noise here along the borders of the skull base. But in fact, this was made much worse by the fact that the patient was moving. This patient had a lot of trouble being imaged. They were claustrophobic, a not uncommon scenario for those of us who have a clinical practice. But I was blown away by how much improvement I got just with using AiCE. So not only is that noise resolved, but the motion was really, really reduced in terms of its effect on the diagnostic quality of my images. And in fact, I was able to look at this case with much greater confidence when I talked about the fusiform enlargement of all of these extraocular muscles and make the diagnosis of thyroid orbitopathy. This is a case I felt that really showed how AiCE made me look maybe a little bit better as a radiologist. So clinically suspected thyroid eye disease, but the location was not specified on any prior imaging. And so this is not our native image here. And you can see it's good quality, but there is a lot of noise. And in fact, it might be easy to say that this is normal. But when you add AiCE, it is impossible to ignore this asymmetric enlargement of the right medial rectus muscle. And in fact, the elevated internal T2 hyperintensity really nailing the diagnosis of thyroid orbitopathy. This was clinically relevant because with that finding, the patient was able to be placed on a clinical trial for treatment of her eye disease.
So for our next case, we're going to move out of the orbit and into the brain. Here on the left-hand side, I've shown you an example of susceptibility-weighted imaging on the Canon magnet system. And as you can see, this works quite well, and we have appropriate signal in some draining veins overlying the right temporal lobe, as well as expected susceptibility within the basal ganglia. So this is a diagnostic quality image. However, after the application of AiCE, we have this improved resolution and denoising effect, which really helps the radiologist focus in on the critical finding, namely a microhemorrhage in the infralateral right frontal lobe. That doesn't seem like a whole lot, but when the clinician is asking you to rule out cerebral amyloid angiopathy, as was the case in this particular set of images, this is the absolute critical finding to make, which I feel is facilitated by the use of the AiCE technique. This next patient had a known diagnosis of thyroid orbitopathy, and so certainly involvement of the inferior and medial rectus muscle wasn't in question on these regular coronal T2 stir sequences. However, what wasn't readily apparent from the initial imaging was why there would be bilateral involvement clinically. However, after reviewing the images with the AiCE protocol, we definitely have improved resolution of involvement of the inferior and medial rectus muscles. But what becomes slightly more evident is that there really is asymmetric T2 hyperintensity in the left inferior rectus muscle, which explained at least some of the clinical underpinnings indicating bilaterality in this patient with known thyroid eye disease.
We do a lot of spine imaging at UCSD, and as many of you know, patients with a larger body habitus really can present an imaging dilemma because of the decreased signal to noise that you're going to get, especially on a 3 Tesla magnet. So here's an example of a patient with a large body habitus without and with AiCE. You can see this is a much more visually pleasing study, but in fact we have much better resolution with no additional acquisition time for this patient with a large body habitus, which is yet another advantage with AiCE. Certainly we can make the finding on both the native and the processed images. In this case, there is a disc protrusion at L4, L5. But the real advantage of AiCE in this case, I think, comes from the denoising of the axial T2 sequences, where I'm able to better describe that disc protrusion and really see its close relationship with the traversing nerve root at this level and potentially explaining a component of the patient's right-sided radiculopathy. This is a sagittal but far lateral view of the spine in this patient who had intractable right paraspinal pain, had prior ablation, and really was still having persistent pain that wasn't diagnosed. And so the facet joint is definitely degenerated here on both the non-AiCE and the AiCE images, but we get better resolution of the actual facet joint space itself. I can tell you that it's in the inferior articular facet, the superior articular facet. But the real power for me of this image is that because of this improved anatomic detail in this otherwise relatively low resolution stir sequence, I can now see this edema in the pedicle 2 levels above. And so this was referred pain from an additional degenerated facet joint. The patient was able to get another ablation and is actually doing quite well. So I was able to see through the noise of this image to make the second diagnosis critical for this patient. Another degenerated spine. Certainly you can see the fibrovascular motor type 1 end plate changes at L4, L5. However, I think AiCE in this case, the improved resolution really shows the additional region of end plate edema along the antero-inferior aspect of L2. This is important to us at UCSD because we have interventionalists who treat these types of changes. And the last thing you want to do is send them in to treat one level only to unmask pain a few levels up. And again, we're going to go back to the orbits, and I think this is a very powerful example. So T2 weighted fat-saturated sequences are going to be part of the mainstay of any orbital or skull-based protocol, but this is an area that is very difficult to image. The anatomic structures you're looking at are very small, and there's a lot of susceptibility from the adjacent bone, and in this case, a very well-mimetized sphenoid sinus. This is an example of our native coronal T2 fat-saturated sequence. There's an interplay between different types of sequences. Some people like to use a stir sequence because of that decreased susceptibility, with the trade-off of it having slightly lower resolution. But I had an idea that sort of bore out that I could use AiCE to bump up the resolution of my stir and then have the advantage of the decreased susceptibility. And in fact, these are acquired at the exact same level. And what you can see is using stir plus AiCE, I have the same, if not better, parenchymal resolution. But look at this. That susceptibility, that loss of signal related to the sphenoid sinus has now been completely mitigated. And I can see perfectly the foramen rotundum and the cranial nerve V2. So a case of AiCE allowing me to selectively exploit different sequences for improved resolution of the skull base. Here's another case of denoising on a coronal sequence from the AiCE protocol. And certainly I get great resolution here of the semicircular canals and the left cochlea. But what the advantage was on this case is that I get better parenchymal detail on this otherwise noisy image. So I'm really getting the most out of every sequence that I acquire. This was done for the skull base, but it's also giving me a better chance to look at and identify pathology in the brain. We also do MSK imaging on this magnet at UCSD. And with the AiCE protocol, I think you can better see some of this T1 hypointensity and trabecular change that we have in this patient with a stress-related injury of the right femur. You can also see edema better on this fluid-sensitive sequence with the AiCE protocol here. But what's of an advantage to me as a neuroradiologist reading outside of my specialty is that these denoised images really help show you different types of edema in other structures, whether ligaments or muscles. So it helps me become a more confident radiologist reading outside of my specialty. Now, I've spent a lot of time talking to you about resolution. Resolution is the name of the game in academic institutions, but we are living in the intra-COVID era, and a lot of our institutions are facing very unique and unprecedented pressures about increasing efficiency. So I had an idea, and I'm showing you here our original sagittal T2 protocol in the lumbar spine. We use high matrix, so it was about 4.5 minutes. However, using different values of AiCE, I was able to decrease our acquisition time all the way from 4.5 minutes to 90 seconds. And there is no trade-off in terms of resolution. I still have spectacular osseous and intrathecal detail. So with all of us facing the pressure of trying to increase our patient throughput, decrease scan times without sacrificing resolution, I don't know how your institution is going to do it, but this is how we are going to do it on the Canon magnet. And finally, although this may not be entirely fair, I had the opportunity to repeat image a patient that I had seen 2 years prior. And the patient came back in for this new disc extrusions and symptoms referable to it. But just knowing that I have 3 Tesla, this was a 50% faster exam time done with the AiCE protocol. And I haven't lost anything. In fact, I feel like I've gained resolution. The only thing I've lost between these two sequences is the noise, and everything else has been a benefit. So I hope that I've been able to show you some compelling images, really highlighting the power of the AiCE technique, the world's first fully clinically integrated deep learning reconstruction for MR, which really places Canon at the head of the forefront of MR imaging. Our integration has been seamless from day one. And I will tell you on a personal note that Canon made a lot of really, really lofty promises to me when we started on this journey together. They promised me that they would have improved resolution, decreased scan times, and no further work on the part of myself, the clinical radiologist. And my metrics on all fronts have not only been met, but surpassed by Canon at every turn. So they have exceeded my expectations, and I know that they will be able to exceed the expectations of many other academic and private practice institutions. And so with that, again, I'm Marin McDonald. I am a clinical neuroradiologist at UCSD. I am readily Googleable, and I am passionate about MR imaging and happy to speak to anyone at any time about the use of AI in MR imaging and the Canon Medical imaging system. Thank you so much for your time, and I wish you a very productive and safe conference.